طيب السلام عليكم. I think it's time to start. So the aim today is to have it interactive. So please feel free to stop me, ask question, unmute yourself. So I prepared two cases. I'd like to go with you. Both I found challenging. So the first one was 93 years old lady who was diagnosed with CLL in 2018. She was given chlorambucil. However, I mean, her disease remained stable. So she was referred to me in February 2020. It was like 1 month before the COVID pandemic. She was complaining from severe B symptoms, night sweats, fever, itchiness. And at that time, her WBC was 600,000 plus. She was anemic. Rated was borderline 100. And cytogenetic at that time showed B53 deletion. IGVHD was unknown. We were doing it as a send out in our hospital, and at that time, with the COVID, actually the send out was stopped. Her performance status, ECOG is 2, and she's diabetic, hypertensive. So the question is, how would you manage such a patient? Any thoughts? Okay, so let me tell you what I did. This is very famous table. So you have to define your patient is either go or slow go. As I mentioned in the presentation, I mean, ECOG alone is not the best way to assess the fitness for older adults. SPPB is a very important tool. This is a link for a YouTube how to do it in 10 minutes. And there is an application how to do it. It consists from lower extremity strength, chair assessment of the chair, changing of position, as well as gait speed. And then it give you interpretation between severe limitation, minimal limitation. So my patient at that time was having a moderate limitation, whether it's a disease related, and this is what the family claimed actually, it was disease related rather than a chronic or biological issues. We have defined that she is a slow go when it comes to the fitness, and then what are treatment options that we can offer this patient. This is a very long list of options, and she's having very bad disease, which is P53. Additionally, although hepatic profile was normal, but the serology that she's having a hepatitis B antigen, and the viral load came to be 65 million as an additional challenge. So what's the fitness for targeted therapy in older adults? So if you look at some of the CLL studies, and this, I mean, the largest documented, at least in literature, was 91, I found, and definitely the age does add to the toxicity. Each 10 years in this multivariate analysis carries a hazard ratio of 1.87. It was an independent risk factor. When you look at the venetoclax studies, actually the upper age limit in the studies I reviewed was 88. And there was no impact of the above 75 versus less than 75 when it comes to the adverse event. However, this is a recent presentation by the Italian group in the last SOHO, and they found actually the age as well as the fitness carries an important factor when it comes to the toxicity of venetoclax. So what I have decided, based on the age, based on the performance status, as well as two important factors, that she's having a hepatitis B. So we started her on anti-hepatitis B, and the very high very high WBC count. Because of that, I was very concerned from adding venetoclax. And as I said, that ibrutinib, there are concerns from that, whether it's a bleeding, cardiovascular, arrhythmia. So I said, let me put her on fludarabine rituximab. Probably I will suspend rituximab for time being because of the hepatitis. So I started her on fludarabine, and although she missed, so I started on fludarabine oral tablet because I thought it would be more convenient for her not to come to the hospital. Maybe she skipped one cycle. However, actually there was good response when it comes to WBC. After the first cycle, the B symptoms, there was significant partial improvement. WBC count continued to drop. And when I saw her 2 weeks ago, it reached around 200. So the aim is probably that once we have a control of hepatitis B, probably I will add rituximab, and we'll see what we can do further. So this is the first case. Any question, any comment, any suggestion on how to treat her? Okay, so I will move to the next. So the second case is a little bit complicated patient. So this is a 54 years old male. I mean, he was diagnosed in 2015 with CLL stage 0. 2 years later, he required treatment because of dropping in platelet and hemoglobin. He received FCR. At that time, his cytogenetic was normal, and IGVHD was mutated, and achieved PR. He did not go into remission, but his counts improved, and there was no further indication for any treatment. Approximately 2 years later, he had a relapse of CLL, and at that time, P53 was, he's having a P53 deletion, so he was put in an ibrutinib. He responded very nicely. Actually, he achieved complete remission. Repeated cytogenetic assessment was within normal. Everything was within normal. He's having a bad blood diabetes, which is poorly controlled in insulin. However, around actually 2 months after starting ibrutinib, he started to complain from skin lesions. Initially, we were limited. We tried to do biopsies, was inconclusive. We gave him initially local treatment, local antibiotic, then oral antibiotic, and then it started to get more disseminated. So it was maculoerythematous plaques with necrosis in the center. It looks like a target lesions and affected even the face. There was a question whether it's cellulitis, and if it's a facial cellulitis, so we admitted him for IV antibiotics. So he received a lot of antimicrobial treatment, as well as he had multiple biopsies. The biopsies, the pathology we received was query insect mite related versus drug eruption. He denied any insects. And there was, if you look at the pathology itself, there are still infiltration of lymphocyte and eosinophils. There was no evidence of disease, that it is an extramedullary CLL. So the impression that this is probably an ibrutinib related. So what would you do? Any thoughts? Okay. So So as I mentioned that at the beginning, we could not exclude infectious causes, even by pathology. So we started him in broad spectrum, initially oral antibiotic, then IV antibiotic. At one time, we added antifungal for him. It was empirical. Then he actually went for second opinion in Mayo Clinic, and they put him on double antifungal. However, the lesions, they did not stop. There was some improvement, but usually transient and short-living. One time initially when it was very mild, we reduced the dose of ibrutinib, and then when it became more severe, then we suspended the medication and we gave him drug holidays. There was some improvement, and then we restarted the ibrutinib at a smaller dose, and the same thing continued to happen. And then we reduced the dose to 140. However, the patient by himself actually did not take the medication and did not notify us. So if you look at the skin rash, it accounts for 27%, and in the first year, and then it decreases with the time. Because it was very severe, and the exact mechanism of action is not very fully understood. However, there are suggestions that it might be EGFR related, IgE mediated. Sometimes it might be viral reactivation. So as I say that after significant improvement, we restarted the reduced dose. However, the patient did not take it and did not notify us. Then after 3 or 4 months, then actually he started to have a disease relapse. So if you look at the incidence of ibrutinib discontinuation, overall, the incidence is very low. The progression of disease in the first 1.5 years is around 2.4. There is 6.5 incidence because of Refractory transformation, and the side effects that led to discontinuation of ibrutinib were 15% in the first 1.5 years. So this is his WBC. After stopping the treatment, he started to have increase of WBC associated with drop of platelet, reached single digit in some readings, as well as his hemoglobin. Again, I mean, the staging again was done for him. It was consistent with relapsed CLL, no Richter transformation, and the cytogen was B53. So the question is, what to do with this relapse again? How to select the second-line treatment, or actually for him it will be the third-line treatment. So there are recommendations when it comes to chemoimmunotherapy, BTK inhibitor, venetoclax. So for our patient that he was using BTK inhibitor, and the reason is the intolerance. And as we were discussing before the breakout, actually, BTK, the test for BTK mutation or for BCL2 mutation is recommended when patient fail to respond to one targeted therapy. So our patient falls in this category, intolerance to BTK, and then the options are, because we don't have the mutations, the options can be either venetoclax-based therapy or alternate BTK inhibitors. So if you look at the BTK inhibitors, there are currently 3 generations of BTK inhibitors. The first, as we are all aware, is ibrutinib. The second generation is acalabrutinib and zanubrutinib. And then there are third generation, which are undergoing clinical trials, not yet approved. Those agents varies when it comes to the kinase activities and selectivities. Some are more potent, like acalabrutinib is more potent in BTKA. And when it comes to the approval, acalabrutinib is approved for as a first and subsequent lines of therapy, as a monotherapy or in combination with the bevacizumab, similar to the ibrutinib. Zanubrutinib is currently approved only for mantle cell lymphoma. So how would you select between BTK inhibitors versus BCL2 inhibitor venetoclax? So the way I do it is the problem with venetoclax is when I have a patient with very high risk of tumor lysis, as the previous patient was 600, I mean, definitely, I mean, it's recommended to admit hydration, respiratory cares, but still, I mean, the risk is very high and the renal failure is, the incidence is very high for her. If patient is requiring or using strong CYP3A inhibitors when it comes like antifungal, this probably would be issue. And when you have a patient with renal impairment, these are clear. I mean, put me more in favor of BTK inhibitor like ibrutinib or the other agents. For venetoclax, if there is a patient with uncontrolled hypertension and there is a high risk of bleeding, cardiovascular anticoagulation, I might prefer venetoclax over BTK inhibitors. Other points to keep in mind, currently venetoclax treatment is limited for 2 years with addition of rituximab. However, the BTK inhibitor is lifelong. However, it is expected soon that probably there are many ongoing studies for the duration of BTK inhibitor. Probably it will be similar to venetoclax. This is what we are hearing, the initial or preliminary result, but it will be published as I was told in the coming ASH. Another advantage of ibrutinib or specifically is that the safety margin, it has been now in the market for a very long period, and it is very well studied in comparison to the other agents. So I put the patient on venetoclax and he plus rituximab, and he completed 6 months, and he achieved remission, including cytogenetic remission. The plan now is to do bone marrow aspiration to assess for MRD, and then the question after that whether to do bone marrow transplant or not. If anyone has any comment, please feel free to interrupt, unmute yourself and ask, or put in the chat. So, should we offer this patient transplant or not? So the use of transplant for CLL has declined after the introduction of targeted therapy in 2012 specifically. I mean, the numbers start to decline in the US as well as in EBMT. There is no prospective randomized study of transplant versus no transplant in CLL. However, there are some studies looked at into this. Harvard-Nebaja paper, he used Markov decisional model, transplant versus no transplant, and I mean, when it comes to overall survival, transplant was superior. Life expectancy, there were around 10%, 10 months extra, but it also has significant non-relapse mortality, which is 22 versus 8%. There are a study donor versus no donor. The 2 years overall survival for those who underwent transplant was better. And this is for selective group with high risk disease, with like a P53 or deletion 17, relapsed refractory. Several research groups published their own experience. Just want to highlight that chronic GVHD and severe chronic GVHD is unfortunately might happen in 50% of the patient. Median overall survival between 50 to 60%. However, it's as a treatment option. And the current recommendation is that the indication for transplant shall not be considered except that after the failure of the first novel agent. After that, this has to be discussed with the patient wishes and expectation. taking into account the disease risk as well as transplant risk when it comes to the age, comorbidity, availability of donor. And I think this is my last slide. So if anyone has any question or comment. any comment دكتور نعيم؟ طيب, I think that's all I have. I think we will be switched to the other room for challenging cases in the upfront management.
Yes, Doctor. We are waiting for the other breakout to finish. Then we will switch the attendees to attend the other cases.
Yes, Dr. Zaidi. Can you mute yourself?
Yes, very interesting cases you presented, and I do see a couple of cases with ibrutinib causing milder rashes, and one with bully. Yani like once I thought that it may be herpes or something, but it was not distributed. And withholding of 1 to 2 weeks of ibrutinib and giving a short course of steroid helped. One more time it recurred in the same patient, same strategy, and now for last 2 years there is nothing. She is enjoying very good remission. This is one. Your patient which had blackish necrotic lesions, that is too much to have on the face also, probably more likely infective, fungal. I missed your discussion that it proved to be fungal, right?
Here no, actually, so multiple biopsies all are negative. So, and we put him empirically, and we put him empirically on antifungal. Because as you said, that there is a clinical suspicion this might be fungal even if we fail to isolate it in the pathology or the cultures. I mean, there was no...
someone outside gave her double antifungal, I heard like that.
Yeah. So then he went to Mayo Clinic for a second opinion. They put him on double antifungal.
Right.
But again, so it's, to me, it seems to be superimposed infection.
Yes.
But I mean, he had some partial responses, sometimes to IV antibiotic. I did not notice a big improvement with antifungal, and we ended giving him ambidom for a certain time.
Right. But I will not give such a patient again ibrutinib at all.
Yeah.
They do cause some.
Yeah. So initially we reduced the dose. There was no improvement. Then when it became more serious, then we suspended. And even after suspending, I have to say, the lesions started to disappear. I mean, or did not recur after venetoclax. When he started venetoclax, all the lesions disappeared.
Yeah, wonderful. Okay.
So this is really strange.
Yeah. I learned something.